Of course, first thing that comes to your mind is we want to do ECG to find out what is the palpitation. As mentioned before, not all of them will have palpitation by the time they come and see us. Of course, as we know, other causes of palpitation including hypoglycemias and all of that. So we wanted to check blood sugars and a basic blood test investigation, including thyroid function test. Now, just a quick overview on the ECGs. I mean, ECG itself is the way that we look at the heart electronically. The 12-lead ECG itself represents more or less 360 degrees of the electrical activities of the heart. If you look at the limb leads, they look at the heart on this plane, and the chest lead will look at the heart on the horizontal plane. If you apply the principle of the positive electrical activities moving towards the leads will give you positive deflections, then you can actually try and locate where is the VPCs or the palpitations coming from. Again, as mentioned before, all patients should have an ECG regardless whether they have palpitations or not. But as mentioned before, catch the right moment is not easy. But if you have to pay particular attention to the important ones, then you may be able to catch these nice pictures. But you have to be at the right spot at the right moments. Now, let's start with a simpler ECG. Does anyone volunteer what would be the diagnosis? You can see that almost all of the QRS preceded by P-wave, and the rate is about 150. It's quite regular, so most likely this sinus tachycardia. And the next one, again, same thing. The rate is slightly slower, but you can see P-wave in every QRS. Occasionally you see these early beats. The QRS morphology looks more or less the same. You could argue that this one looks a bit different, but if you follow this one, that T-wave is abnormal because of the presence of early premature atrial contractions. So this is a PAC. What about this one? A bit more simpler. Looks irregular. How many of you think this is a VT? Show of hand. One or two. How many of you think this is not a VT, excluding Dr. Koh? It looks irregular. One of the features of VT is tend to be more regular. So the other thing that we want to see is the axis, which is normal, and the QRS itself is not broad. But if you say this is a VT, you could be forgiven because the treatment for VT is more or less the same for SVT with aberrancy. Whereas sometimes if you're mistaken to treat SVT with aberrancy, particularly if you were to give verapamil, the outcome could be worse. And this patient actually reverted to sinus rhythm. So the diagnosis will be, if you can see that clearly, there is a delta wave, a short PR interval is delta wave. So this is representations of both Parkinson-White syndrome or and accessory pathways with pre-excitations. The patient had fast irregular beats was because almost all of the electrical activities in the atrium bypassing the AV node conducted down to the ventricle. The risk for this patient would be is that if it goes very, very fast, atrial fibrillations, it might just translate to ventricular fibrillations. Although the risk is actually very, very small, less than 0.1% on any patient with WPW. So not to worry. I mean, if it's a patient with WPW, those are the possibilities, but most of them will not have VF. Right. This is another examples of ECGs that we can get in a GP setting.